syndrome. Lamberton-Eaton myasthenic syndrome, being abbreviated to me as a word LEMS. Now, how do you see the disease LEMS? It's like this. We have a neuromuscular junction now. Now the problem this time comes on the nerve. Why? Because I know this, firstly the acetylcholine which is synthesized inside the nerve terminal has to be there. It has to come to the synaptic area here. And now coming here, this acetylcholine molecule has to attach to this synaptic vesicle. Correct? To attach it well, there are two proteins which are working here. So I'll draw slightly above here. So this is an acetylcholine molecule with me, right? Which happens to have a particular protein on its surface, which matches with the protein on the nerve membrane surface. Now this is something you read in physiology, in neuromuscular junction transmission. The vesicle has got a protein, yes, which is very brave. Name is synaptobravin. Now this nerve membrane has got a protein at the synapse which pays the tax, that is known as syntaxin. So one is a brave protein, synaptobravin, on the vesicle. Other one is a syntaxin protein on the nerve membrane which pays the tax. But who is going to throw this acetylcholine molecule out of the nerve tissue? The push has to come by the influx of a cation into the nerve tissue, whose name is calcium. Now the influx of calcium happens with the help of certain channels over here, which are known as a PQ type of calcium ion channels. Now remember this, these PQ type of calcium ion channels happen to be voltage gated. The word voltage gated is applied to them for the reason that when the nerve impulse will come over there, the voltage will come, then only they are going to open up. See, the calcium channels we have discussed so many times till now are opening by a glutamate molecule, right? Which was ligand gated. Now glutamate is a compound which is a ligand, but this is a voltage gated channel, PQ type of channel. Now what happens is this molecule comes and attaches to the receptor below on the muscle tissue. Fine, this we know. Now the punga is this. A patient of LEMS starts with the story of a malignancy. The malignancy is small cell carcinoma of the lung that you find in smokers, SCC lung. Now, if my body sees a malignancy any time, it is going to fight against it. But production of what? Antibodies. So antibodies are created against the malignancy, but may not be that successful to deal with it. But the problem is these malignancies antigenically mimic this PQ type of calcium ion channels. So antibodies against the malignancy will come and cross react with these PQ type of calcium ion channels. So what will happen in the long run? These channels are going to close, and finally there is no release of acetylcholine from the nerve terminal, even though the impulse on the nerve is coming to release it. Correct? So we see this drama as a presynaptic defect. Presynaptic defect 1 on the PQ type of calcium ion channel, finally causing what? A decrease in the acetylcholine release. Decrease in the acetylcholine release. Okay. Associated with a malignancy, a small cell carcinoma of the lung. Right. Now when I see these patients clinically, the weakness that you find in these patients is typically seen first in the skeletal muscle, followed in the nature by your facial muscle, and the last is the ocular muscle. So the first and the most common muscle group involved is skeletal in them. The last and the least common involved in them is ocular. If you remember, in myasthenia is just the other way around. Ocular first, skeletal last. Deep tendon reflexes that you check with a knee hammer are found to be dull and absent in them. That means they suffer with hyperareflexia. And of course, something that was normal in a myasthenic patient, bladder, is found to be involved in them. So there is a bladder involvement due to autonomic problems in them. Okay. Investigation. we found that we could do an edrophonium in them as well. So what is an edrophonium compound which I explained you? It was a faster and a shorter acting acetylcholine esterase inhibitor to bring up the acetylcholine level so that more acetylcholine is there in the synaptic cleft and more it touches the receptor and depolarizes the muscle, right? So just imagine this. Just an arbitrary example I'm giving you. By chance, by mistake, there is one acetylcholine molecule out in the synaptic cleft with me, and that esterase enzyme from behind is going to eat it away. So I inhibit this enzyme so the acetylcholine molecule remains with me for a longer time. Now do you think if it remains there for a longer time or a shorter time even, will it go and attach to only one receptor? No. It will go and attach to every receptor. So the weakness that you found in patients of myasthenia was improving on giving this drug, while in LEMS also it will improve. But the problem here is it is weakly positive. Now look at this name, weakly positive. Why? Not as strongly as a myasthenic patient, but it is positive. In a sense, it's subjective, weakly positive. So you write it down. In these patients, the edrophonium test is found to be positive, but we know this, it's found to be weakly positive. I'll show you an image to explain this better. Aha. Remember this madam? She was suffering with ptosis, maybe a snarling appearance. She got a boyfriend or not, I don't know that, but she got an edrophonium of almost 10 mg and her eyelid open and her facial appearance improved. That was a tensilon or the edrophonium test done in a patient with myasthenia gravis. Same kind of a response, very fast and quick, won't happen in your LEMS patient. They will just have a minimal improvement of ptosis or something, okay? So just remember that edrophonium is positive in them as well, but it is weakly positive. Now we do this test, rapid nerve stimulation, RNS. Now we find somewhere at two things, If rapid nerve stimulation is done at low frequencies in these patients, we will find a decremental response. What was the decremental response? As you keep on stimulating the nerve, the action potential will keep on dropping. But they say if you've done this kind of a RNS at a higher frequency, then what would occur? Just imagine this. This is a graph that we want to plot. We have the nerve, action potential, and action potential. The first three action potentials in the muscle that I find, will be low, but in patients of LEMS, when I increase the firing rate in the nerve, fourth and the fifth, the action potential will be better by almost a magnitude of 10%. So look at this please. At a higher frequency, when I stimulate the nerve, maybe some calcium channels which are not affected by the disease, but they require a higher firing rate, maybe they are going to open up, causing more calcium influx in the nerve, more release of acetylcholine. And there was absolutely no problem on the muscle. So they could easily attach to the muscle tissue. So you find in them what? An incremental response. So remember this, in patients of LEMS or a higher frequency stimulation in a rapid nerve stimulation technique, they found an incremental response in them. Treatment. There's a very old drug which is still given to them. That's a 3-diaminopyridine or the 3-DAP. Remember, this drug happens to work like this. It increases the acetylcholine release from the nerve tissue. So it tries to increase the acetylcholine release from the nerve. Okay, remember this much only, it's more than sufficient. So 3-DAP is a drug which is advised in these patients to increase the acetylcholine release from the nerve and improve the weakness. The RNS at a higher frequency will show an incremental response. Edrophonium could be weakly positive. The weakness is first skeletal, last ocular. Reflexes are involved, bladder is involved. This problem happens to sit at the PQ type of calcium ion channel because antibodies have come and attacked it, because those antibodies were directed against the malignancy, small cell carcinoma of the lung. So in a nutshell, what you understand, this the malignancy came first and the disease comes after that. So you see this as a paraneoplastic syndrome. Paraneoplastic syndrome. Okay. So this drama and this problem is more often a paraneoplastic syndrome that we know. Okay. Fine. So let's see some related questions to this topic. 45-year-old male presents with 2-year history of progressive weakness and severe dry mouth. On physical examination, he has got bilateral proximal arm and the leg weak, along with absent reflexes. After repeated nerve testing of the quadriceps muscle, his strength improved and the patellar reflex appeared. The nerve conduction testing and sensory responses are normal. Motor response had a low amplitude were normal, but repeated nerve stimulation done at 50 Hz, that is higher frequency, is shown in this image. So if you look at this image, what is this? There is nothing but your typical incremental response. At 50 Hz, that's a higher frequency. Now look at this drama again. On repeating testing of the quadriceps, the strength improved. So I keep on testing the quadriceps. I keep on doing a rapid nerve stimulation on him. And now there is an incremental response, correct? So in myasthenic patient, as they keep on walking, they develop fatigue. But in LEMS, they keep on walking and they get better somewhere. So these are the two contrast kind of events that you find. Okay. Now the question starts from here. That this disease, which of the following is true? Okay. It occurs due to post-synaptic musk antibodies. Nah, that was myasthenia gravis patient. That too bulbar, 10% of myasthenic patients only. This disorder is commonly associated with colon malignancy. No, only one malignancy I kept on telling you, small cell carcinoma of the lung, not the CN or any carcinoma of the intestine. Spores of honey are responsible for this condition. Now, what is this honey doing over here? There was a lot of drama about honey recently, the adulteration thing and all. Somewhere if you work in pediatrics, they will always tell you that you tell the grandmother not to give the grandchild at birth honey. Otherwise the child is going to die because of that honey. Why? Because honey spores, honey contains, somewhere some spores of some toxin, the botulism toxin. Remember that? So there is a botulism poisoning, How does it really work, botulism toxin? There is an acetylcholine molecule which is supposed to get released from the nerve. The botulism toxin inhibits that. Correct. So if you remember, the botulism poisoning happens to cause a lot of neuroparalytic picture like this because acetylcholine is not released. When acetylcholine is also not released in the autonomic system, so there will be GI symptoms like constipation and all that. So they have got a mixture of GI problems and neuroparalysis because botulism toxin inhibits the release of the acetylcholine from the nerve tissue. Best answer is a presynaptic voltage gated calcium channel antibodies are present. This is nothing but your case of LEMS. Right? Fine. Now let's move into another zone that maybe you will read in pediatrics again, but I need to discuss few points on this. That's known as a Duchenne